This is Michael Barraza returning as your host. I'm excited to welcome Dr. John Smirniotopoulos to share his experience performing genicular nerve ablation. So let's talk about equipment. There are tons of different RFA probes of different types. And you mentioned the one that you use. Like, how do you choose an RFA probe for this? And, what are you looking for in terms of the type of RFA and ablation size?
Yeah, so there's a lot, as you said, that's out there. There's a lot that's been studied historically out there. We use Avanos cooled RF, so it's cool leaf, that's the name, even though it's heat. The idea, similar to osteocool, there is some saline that's being circulated around the probe tip. It is reducing the amount of char that's formed. Therefore, it's not as self-limiting as traditional RF, and you get a more uniform, about somewhere between 0.5 to 1 centimeter ball of heat to cause that ablation. It's just more uniform and more guaranteed. If it's superior to just standard pulsed RF, that is not really borne out yet. It hasn't been studied yet, but conceptually, that makes sense that you have a larger ball of heat. You're probably going to capture some of that variability of the genicular nerves based on those anatomic studies I was talking about. And so that's why we use it. It's also where a lot of the data has come from using that specific probe. And so if you trust the data, then I would go ahead and use the product that's been shown in the data to work very well. But that being said, people also do cryo for this as well. So other institutions, they'll use a cryo probe. And the thought behind the cryo probe is you can visualize it under either ultrasound or CT, right? You can see your ablation zone. You may have a theoretical decreased risk of damaging any muscular structure or tendon because of that control. And again, you are using a cooled device to cause the destruction of the nerve. Plus, you're likely to get some more Wallerian degeneration using cryo than you are heat. So that backtracking of the nerve dying. So there's some, argument to be used for that too. That has its own pros and cons associated with it. If you do a lot of cryo in general, you're going to use up your argon gas. How much do the probes cost? So some of the kits that we use come in 2 or 3 probe kits. So you can go ahead and ablate 3 spots at once and you're kind of in and out of there as opposed to doing one at a time. So it just really is up to your comfort. It takes a while. Yeah.
So do you do just one spot with each needle, just burn?
Yeah, so that's a really good question. That's how we started. We had those 4 points, and one of my partners, because I got all of us trained up to do this once the volume got too high, he likes doing the 3 spots. And there's data to suggest from the pain literature that 4 spots is superior to 3 spots. In our own unpublished sub-analysis, that's not borne out yet. But in any case, we start off with doing 1 probe at each location. So again, suprapatellar, the superior lateral and supromedial genicular nerves, and inframedial. Since that cadaveric study came out and I read about it, there was also another study in the pain literature suggesting improved outcomes from doing more than those 4 spots. And in particular, a kind of pullback technique for the superlateral and supromedial. It's a study that came out, I think, last year, and they had very good results. The idea, again, is that you have variability in where those nerves lie, and specifically the superior genicular nerves. They come from both the sciatic and the common femoral. And so there's just variability on the patient where that's going to go. So I myself have been doing the pullback technique, meaning I'll go ahead, I'll ablate the suprapatellar and I'll ablate the inframedial at the same time. So we have a 2 probe kit for our purposes. 2.5 minutes of RF ablation, reaching 80 degrees temperature.
That's not bad.
Yeah, not bad. Depends on your patient. It might feel longer than it is if they're not that asleep. They'll be squeezing your nurse's hand. That's fine. But you do those, then you take those probes out, and then I ablate the supromedial, superlateral at the same time. I'll go deep with it. So you're trying to get the distal tip of your RF probe about 2/3 of the way down. That's because it's going to generate a ball of heat that's distal to the probe tip itself by about 4 millimeters. So some of these probes, especially the cool leaf probe, it comes with a radiopaque marker on it. The ablation zone starts actually a couple millimeters distal to the radiopaque marker, and then it extends beyond the tip itself. So you want to get the tip about 2/3 depth, do your ablation for 2.5 minutes, and then pull back to about 1/3 depth. Repeat the ablation there. And I think what's important to take away is that prior to every ablation, we do a motor stimulation test on these patients. The probes allow us to do that. There's an actual stimulation function on the screen. You hit that, you turn it up to 2 volts, and you're looking for any muscle twitching. Sometimes you'll see the probe beat on its own. That's okay. But if you see the muscle twitching, it's not subtle. It's very obvious. And then you adjust. But more importantly is that I repeat that test when I do the pullback technique just to make sure I'm not hitting anything superficial that's there.
Do you do that with all of them or just the superior, the motor test?
Oh, the motor test I do for all of them. The motor test I do for all of them. The suprapatellar is where you definitely see it the most in the knees. Now, we also do this procedure for the hips, and I have seen it for the obturator, and we have to adjust. But for the knees, the suprapatellar is where you see it the most. If you do see it for the suprapatellar, my recommendation is to adjust a little caudally, not cranially, because you're going to get off the motor neuron for the vastus and get more on the sensory motor neuron. Now, if you go too caudal, then you start flirting with the capsule there, and you do risk ablating the capsule and causing a transient synovitis there.
So aside from motor nerves, are there any other structures in the area you really need to worry about?
Yeah, I mean, the joint capsule is probably the biggest one. And so that if you read enough of these kind of case reports that are out there, you'll see some people that have had complication with a transient synovitis or some type of maybe hemarthrosis. And so I do warn the patient that that's one of the potential risks is having some inflammation there that may require arthrocentesis or something of that nature. The motor neurons are absolutely the biggest concern. And frankly, I haven't seen much fasciculation except for that suprapatellar, but I still test everything. And it is a conversation I have with the patient that it is transient. It won't be permanent, but that is a potential risk factor.
Okay. Any other complications that you've seen frequently or that you worry about?
No, I mean, occasionally, we're doing this under fluoro in our practice quite a bit. You may put in your trocar, 17 gauge trocar needle for your ablation, and you may pull that inner stylet out and you're going to start seeing blood come back. If you do it enough, you'll see it. What that means in my mind, and comparing this with ultrasound, is you're probably on the neurovascular bundle for the genicular nerve. Some of the guidelines will say, put the stylet back in, adjust. I don't think you have to necessarily do that. My thought is that if you're ablating it, you're going to have some type of thermal coagulation at that point, and it might actually make you feel that you're actually close to where the nerve is, a little bit more so than if you're doing it, just based off markers. But you can develop a potential hematoma, with that being said.
Yeah, it's not in a challenging spot to control, I wouldn't think. And we're not talking about ablating the popliteal artery.
Right, exactly. So. It's relatively safe. And I think all of us in IR are very comfortable messing around with blood vessels. A lot of the other physicians in the country that do this maybe are not. And so, yeah, when the reps train you, they're probably used to training those other types of physicians. And then if we see blood, we're like, okay, I can stop this pretty easily. And that's just our specialty.
Okay. Let's talk a little bit about the follow-up. And one of the most important things, I think, for pain intervention is setting reasonable expectations. And so I'm curious how you counsel these patients before genicular nerve ablation on what they should expect in terms of the degree and the duration of pain relief.
Yeah. And I think the counseling and setting expectations might be the most important part of any pain procedure that we do. It's all about setting up expectations. So I tell the patient, for the block, we're looking for 50% or more reduction. They're likely to have something similar to that when we do the ablation if they're a candidate. Again, we're not a time machine. I'm not reversing their cartilage damage or their loss. Certainly if they're post TKA, I'm not taking away their hardware or whatever's irritated there. And I think that's very important to really hammer in. But again, I tell them, look, if I can reduce your pain by 50%, cut it in half, and start getting you to a level of activity that you want, that's going to be the biggest benefit to you. And again, that's where the physical therapy comes in. And I really do hammer in the physical therapy. We don't have one particular physical therapist we send people to. However, within our institution, we have so many PT offices in the DC metro area. So my referral form, it's a physical form that I actually give them where I can write down their ICD-10 code. It's a script, but I can also circle what I want the physical therapist to ideally focus on: range of motion, strength, stability, gait training. And then I will write a indefinite number of sessions with them, but they may ultimately need a referral. But more importantly is that I'm the one giving them the script. I'm not asking whoever referred them to give the script. And I think that helps the patient really, one, see you as the person taking care of their pain right now until they may or may not need surgery down the road. But also, if they have something in their hand, it might make them a little more compliant with it too. More importantly, though, I tell them whatever pain benefit they're going to have, they're going to see the maximum benefit at 6 weeks. Not that it's going to go down, but it's going to take about 6 weeks or so to really calm down any inflammation and see how much of the nerve was destroyed, see where their functional status was. And beyond 6 weeks, I doubt that they would improve on their pain. Hopefully, they're not going to get worse with their pain. It won't come back. But that's the maximum benefit. And I've seen that with several patients now because we try to follow up with them at 6 weeks after the ablation. Just a phone call, not necessarily a clinic visit, see how they're doing. And that's what we're seeing is 6 weeks that, it really did start to improve after day 2 of the procedure. Once kind of that soreness from the needles going through the muscle has gone away because they fixate on that. I tell them it's like a flu shot. You're going to go, down the muscle, hit the nerve, and then that'll ease up in 2 days. But some of them will say, yeah, even like 2 weeks after, they noticed a change from 1 week after. And so they start seeing that. So our follow-up is a phone call at 6 weeks. Ideally, I have an e-visit or some type of follow-up at 3 months just to see where they are. And then again at 6 months. And at 6 months is when we start saying, okay, are you doing okay? Do we need to repeat it at this time? And if someone says, yep, pain's back, it worked great, it just came back a couple weeks ago, that's fine. They don't need to have the block again. If they had the block in the ablation, they can just schedule the ablation.
Okay.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTableMSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and Digital Marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Genicular.
Thanks again, and see you next time.